Chapter 53 Diabetes. Diabetes is a chronic multi-system disease characterized by hyperglycemia related to abnormal insulin production, impaired insulin use, or both. It affects 29.1 million people in the United States, and up to 8.1 million unaware, and 86 million that have prediabetes. It is also the seventh leading cause of death. The American Diabetes Association recognizes four different classes: type 1, type 2, gestational, and other. When differentiating between type 1 and type 2 diabetes, there's going to be many differences. The first will be the age of onset, with type 1 being at any age but more common among the young, whereas type 2 is more commonly occurring within the adults. The type of onset could also be a differentiating, with type 1 being very abrupt, though it may have been present for many years, while type 2 being insidious, meaning it developed very slowly until significant symptoms were present. Also within prevalence, type 1 is relatively rare with only 5 to 10%, whereas type 2 accounts for 90 to 95% of all diabetes. Also, many environmental factors could be at play, with viruses and toxins accounting for type 1, while obesity, lack of exercise, and other lifestyle changes could have prevented type 2 in most cases. The primary defect within type 1 is the minimal insulin production within the pancreas, whereas type 2, the body has developed an insulin resistance due to an excess of insulin production. Also, within the islet cell antibodies are present, whereas they are absent within type 2. Type 1 was formerly known as juvenile onset or insulin-dependent diabetes, and it accounts for about 5 to 10% of all diabetes cases. It generally affects people under the age of 40, though it can occur at any age. Type 2 diabetes, formerly known as adult onset or non-insulin dependent. While type 2 diabetes is generally considered a preventable disease, it does have a strong genetic link with multiple genes and metabolic abnormalities, resulting in insulin resistance, a decreased insulin production by the pancreas, inappropriate hepatic glucose production, altered production of hormones and cytokines by the adipose tissue, and as the research continues on the role of the brain, kidneys, and gut in the development of type 2 as well. Metabolic syndrome increases the risk for type 2 diabetes, including things like increased glucose levels, abdominal obesity, high blood pressure, high levels of triglycerides, and decreased level of HDLs. There are 3 of those 5 components necessary to be categorized as metabolic syndrome. Gestational diabetes, on the other hand, develops during pregnancy in 2 to 10% of cases in the United States. It results in an increased risk for cesarean delivery and perinatal and neonatal complications. Should be screening high-risk patients at their first visit, including things like obesity, advanced maternal age, and family history. The average risk results within the 24 to 28 weeks of gestation, as usually glucose levels are normal in the first 6 weeks postpartum. There is a 63% chance of type 2 diabetes within 16 years of developing gestational. The clinical manifestations of type 2 diabetes include polyuria, frequent urination, polydipsia, excessive thirst, and polyphagia, excessive hunger. Also, things like weight loss, weakness, fatigue, and ketoacidosis. For type 2 diabetes, there is nonspecific symptoms, though the classic symptoms of type 1 may manifest. This would be more characterized by fatigue, recurrent infections, recurrent vaginal yeast or candida infections, prolonged wound healing, and visual problems. The major medical complication you're going to be aware of with all types of diabetes is going to be hypoglycemia and hyperglycemia, as their glucose runs completely unchecked. For symptoms related to hypoglycemia, we'd be looking at things like sweating, pallor, irritability, hunger, a lack of coordination, and sleepiness. Whereas with hyperglycemia, we're going to have things like dry mouth, thirst, weakness, headache, blurred vision, and frequent urination. There's going to be many diagnostic studies we could order. The best one would be what's called a hemoglobin A1C, and this one is crucial because it can actually measure the patient's glucose control over the previous 3 months. Many of your diabetic patients are going to be on insulin, and this results from multiple injections a day or via an insulin pump, especially required for type 1 diabetes, It's prescribed for patients with type 2 diabetes during times of stress or as the disease progresses and the body is unable to manage glucose levels with previous therapies. Human insulin is genetically engineered in laboratories from E. coli or yeast cells. Insulins differ by onset, peak action, and duration, though they are categorized as rapid acting, short acting, intermediate acting, or long acting. Here in figure 48-4 from our text, we have a diagram breaks down the different insulin preparations along with their onset, peak, and duration. Especially take note of the graph on the right-hand side, showing the different peaks as well as the length of action of the different insulins. For mealtime insulin, which is used to manage postprandial glucose levels, the first would be rapid-acting insulin, which mimics the natural insulin in response to meals. It has an onset of action in 15 minutes, so it should be injected within 15 minutes of mealtime. Next up would be short-acting insulin. This has an onset of action of 30 to 60 minutes and should be injected 30 to 45 minutes before the meal. Long or intermediate-acting insulin is used with mealtime insulin to manage glucose levels in between meals and overnight. They are released steadily and continuously with no peak action for many people, though the onset can vary. Administered once or twice a day, do not mix or dilute with any other insulin or solution. Intermediate-acting insulin, or MPH, has a duration of 12 to 18 hours with a peak of 4 to 12 hours. It can be mixed with short and rapid-acting insulins, though the cloudy must be agitated to mix. A handy mnemonic is cloudy clear, clear cloudy to use when mixing. First put the air into the cloudy mixture, or the MPH insulin, then put the air into the regular, draw up the regular, and then draw up the MPH. The general thinking is you don't want the MPH contaminating the rapid or regular, in case you needed it for emergencies. This mixture can provide mealtime and basal coverage in one injection. It also comes commercially pre-mixed formulas or pens, though the patient may self-mix from 2 vials. For insulin storage, remember extreme temperatures make insulin less effective. Vials and pens may be left at room temperature up to 4 weeks, and to refrigerate any unopened insulin. Also avoid exposure to direct sunlight, and for hot climates, use a thermos or cooler. When administering insulin, it's always given by subcutaneous injection. Avoid IM due to the risk of hypoglycemia. While regular insulin may be given IV, no insulin can be taken orally, as it's inactivated by gastric fluids. That's actually a very common NCLEX question you'll see out there. Insulin and heparin are never given by PO or pill. Just a trick question you may see out there. There's no pills for it. The absorption is fastest from the abdomen, followed by the arm, thigh, and buttocks. The abdomen is often the preferred site. They do not inject in site to be exercised, and rotate the injections within and between sites. Here in figure 48-5, we just have a chart of the common injection sites. And here in figure 48-6, we have an insulin pen. Remember, never go past the number. Say you were going for 5 units and you went up to 6, waste it, go back, and then go to 5, because once it's dialed in, you can't go back. Many patients may have an insulin pump, and this provides a continuous subcutaneous infusion of rapid-acting insulin. It comes from a small battery-operated device connected to a catheter, inserted into a subcutaneous tissue within the abdominal wall. Change the site every 2 to 3 days. The program basal and bolus doses that increase or decrease throughout the day are based on the patient's carbohydrate intake, activity, or illness. Remember to always check that glucose 4 to 8 times a day, or continuous monitoring. And here we have an Omnipod insulin management system. This is the pod that holds and delivers insulin. It also has, in figure B, the personal diabetes manager to wirelessly program the device. A major advantage of the insulin pumps is that it keeps blood and glucose in a tighter range and avoids highs and lows. The careful programming and constant monitoring makes it possible because delivery is similar to physiologic patterns. It also has more flexibility with meals and activities. Potential concerns include infection at the insertion site, risk for DKA, diabetic ketoacidosis, the cost of the pump and supplies, as well as what's attached to the device. Other problems with insulin therapy include hypoglycemia, allergic reactions, such as local or systemic, and other reactions to the preservative or latex within the rubber stopper. Lipodystrophy may be an issue, resulting from loss of fatty tissue, and atrophy, the wasting away of fatty tissue. Also, hypertrophy, or the thickening of the subcutaneous tissue. Another thing to be aware of is the Somiogi effect, and this is from high doses of insulin that causes decreased glucose during the night, as its release of counter-regulatory hormones causes a rebound in hyperglycemia. The concern is when glucose is checked in the morning and increased insulin is given. Determine if the Somiogi effect by checking glucose between 2 and 4 a.m. This helps to assess the patient for headache, night sweats, or nightmares as well. Another issue may be what's known as the dawn phenomenon, where morning hyperglycemia is present on awakening. This may be due to the release of counter-regulatory hormones in the pre-dawn hours. Growth hormone and cortisol may also play a role, with more severe in adolescence and young adulthood, and the peak time for growth hormone. Newer on the market is an inhaled insulin known as Afrezza. It's a rapid-acting inhaled insulin that's administered at the beginning of each meal or within 20 minutes after starting a meal. Used in combination with long-acting insulins, it has a common adverse reactions such as hypoglycemia, cough, throat pain, or irritation. It's not a recommended treatment for DKA, smokers, patients with asthma or COPD, or others at risk of bronchospasm. For oral and non-insulin injectable agents, these work to improve the mechanisms by which the body makes and uses insulin and glucose. They work on three defects of type 2 diabetes: the insulin resistance, the decreased insulin production, and the increased hepatic glucose production, and they can be used in combination together. The first and possibly most common is metformin. It's most effective as the first-line treatment for type 2 and is available as an immediate release, extended release, or liquid forms. Its action reduces glucose production by the liver and enhances insulin sensitivity. It also improves glucose transport, which may cause weight loss, and is used in the prevention of type 2 diabetes. Remember to withhold if the patient is undergoing surgery or radiologic procedures with contrast medium. Day or two before and at least 48 hours after when serum creatinine levels are within normal limits. It's also contraindicated for renal, liver, and cardiac disease, as well as lactic acidosis. The iodine-based contrast medium can also cause AKI, as both are hard on the kidneys. Also avoid with excessive alcohol intake, and remember to take with foods to minimize any GI side effects. Sulfonylurias. These work to increase insulin production from the pancreas, with a major side effect being hypoglycemia. Examples include glipizide, glyburide, and glimepiride. Next would be incretin hormones that increase insulin synthesis and their release from the pancreas while decreasing hepatic glucose production when glucose levels are normal or elevated. Examples of these would be things like Januvia or Nicena. Next would be SGLT2 inhibitors. They work to block reabsorption of glucose by the kidney, thus increasing urinary glucose excretion. Examples would be Invokana or Jardiance. Dopamine receptor agonists work to improve glucose levels. The mechanism of action is actually unknown. The thought is that patients with type 2 diabetes have low levels of dopamine that may interfere with the body's ability to control blood glucose. The action increases dopamine receptor activity alone and can be used alone or in combination with other type 2 diabetes treatments. Nutrition therapy is going to be key in the case of diabetes. The individualized plan for diabetic and pre-diabetic patients includes counseling, education, ongoing monitoring, and considers behavioral, cognitive, and socioeconomic issues. An interprofessional team, including a registered dietitian with experience in diabetes management, works in conjunction with nurses, social workers, and the healthcare provider. Meal planning should be based on usual food intake and preferences, along balanced with insulin and their exercise patterns. The day-to-day consistency makes it easier to manage blood glucose levels. The rapid-acting insulin, multiple daily injections, and insulin pump offer flexibility based on current blood glucose level and their carbohydrate content of their meals. Emphasis is placed on achieving their glucose, lipid, and blood pressure goals. Moderate weight loss of 5 to 7% improves insulin sensitivity. Nutritionally adequate meal plans are appropriate with serving sizes, and reduced saturated and trans fats, along with low carbohydrates, can decrease calories. Also, spacing meals along with regular exercise. The effectiveness of therapy is monitored by blood glucose levels and that A1C we discussed earlier. Carbohydrates are an important source of energy, fiber, vitamins, and minerals, though the intake is individualized. They should also include sugars, starches, and fiber. They all benefit from including dietary fiber of 25 to 30 grams per day, along with nutritive sweeteners that may be used in moderation. Alcohol should be limited to a moderate amount if no risk for other alcohol-related problems occur. This inhibits the glucogenesis by the liver and can cause severe hypoglycemia. Eating carbohydrates when drinking, unless drinks have sweetened mixtures, and create trust so patients honestly report their intake. For exercise, get medical clearance and start slowly and progress to their goal. Insulin, sulfonylureas, and other activity can make hypoglycemia if it occurs at peak time for the drug or if they didn't eat enough. This may also happen if a sedentary diabetic is suddenly more active. Glucose-lowering effects of exercise last up to 48 hours. Encourage exercise 1 hour after a meal or have a 10 to 15 gram carbohydrate snack and check glucose before exercise. The carbohydrate snack to prevent hypoglycemia every 30 minutes while exercising is also encouraged. There is a risk for hypoglycemia while exercising. Carry a fast-acting source of carbohydrates and frequent low glucose. Consult the healthcare provider about lowering medications if this does repeatedly occur. Strenuous activity makes the body perceive stress, causing the release of counter-regulatory hormones and a temporary increased glucose. Within type 1, delay activity if the glucose is over 250 milligrams and ketones are present in the urine. For the patient and caregiver teaching, first would be an initial follow-up, including instructions how to test, use, and collaborate with the meter. When to test would include before meals, 2 hours after the first bite, when hypoglycemia is suspected, every 4 hours during illness, and before and after exercise. For type 1 diabetes, pancreas transplantation may be indicated, along with end-stage renal disease and kidney transplant. They may also have pancreatic transplant at the same time. If no renal failure, the ADA criteria for pancreas transplant includes a history of frequent, acute, and severe metabolic complications, incapacitating clinical and emotional problems, and consistent failure of insulin-based management to prevent acute complications. Diabetic patients should check their blood glucose every 4 hours during times of illness. If the glucose is greater than 240, check the urine for ketones every 3 to 4 hours. 2 consecutive glucose levels greater than 300 or with moderate to high urine ketone levels should be reported to the provider. Also, increase insulin for type 1 diabetics to avoid the progression of DKA. Medical identification should be carried at all times to identify them as diabetics should an emergency occur. They should also plan ahead for travel, with altered activity levels, diabetes supplies and equipment, along with snacks for emergencies. Check LTSA guidelines. Here in figure 48-11 is just an example of that medical alert bracelet, along with their alert that I have diabetes and how to proceed. Acute complications of diabetes. These complications could take many forms: hypoglycemia, hyperglycemia, diabetic ketoacidosis, and hyperosmolar hyperglycemic syndrome. Manifestations of hypoglycemia include a blood glucose less than 70, cold clammy skin, numbness in the fingers, toes, and mouth, tachycardia, emotional changes, headache, nervousness, faintness, an unsteady gait, hunger, vision changes, or even seizures and coma. The causes could be everything from alcohol intake without food, too little food, too much diabetes medication, too much exercise without food, diabetes medications or food at the wrong time, loss of weight without medical adjustment, and the use of beta blockers interfering with symptoms. The treatment is the rule of 15. Eat or drink 15 grams of rapid-acting carbohydrates, wait 15 minutes and check the glucose. If less than 70, eat or drink another 15 grams of carbohydrates. If stable and meal more than 1 hour away or involved in activity, give carbohydrates and protein. If the glucose remains low after 2 to 3 times, call the provider or EMS. In the case of hyperglycemia, manifestations include elevated blood glucose, increased urination, increased appetite followed by lack of appetite, weakness, fatigue, blurred vision, headache, nausea and vomiting, abdominal cramps, and mood swings. The causes could be everything from illness and infection, corticosteroids, too much food, too little or no diabetes meds, inactivity, emotional or physical stress, or poor absorption of the insulin. Diabetic ketoacidosis, or DKA, is caused by profound deficiency of insulin and is characterized by hyperglycemia, ketosis, acidosis, dehydration, and is more likely to occur in type 1 diabetes. Here in figure 48-12 from the textbook, just is a diagram mapping out the metabolic events leading to diabetic ketoacidosis. DKA manifests as dehydration, such as poor skin turgor, dry mucous membranes, tachycardia, or orthostatic hypotension, with early signs being lethargy and weakness. As it progresses, the skin dries and becomes loose, eyes soften and become sunken. The abdominal pain, anorexia, and nausea vomiting, along with Kussmaul respirations. A sweet and fruity odor on the breath smells like acetone, and a blood glucose level greater than or equal to 250. This also results in a blood pH lower than 7.3, a serum bicarbonate level less than 16, and moderate to high ketone levels within the urine. Monitor and replace potassium before starting insulin therapy. Insulin drives potassium into the cells, leading to hypokalemia, a potentially life-threatening event. Hyperosmolar hyperglycemia syndrome is a life-threatening syndrome, though less common than DKA. It occurs with type 2 diabetes in those over age 60. They're unfortunately able to make enough insulin to prevent DKA, but still have severe hyperglycemic osmotic diuresis. Common causes of HHS include UTIs, pneumonia, sepsis, other acute illnesses. They're newly diagnosed with type 2 diabetes and have impaired thirst sensation or an inability to replace fluids. Also, a history of inadequate fluid intake, increasing mental depression or cognitive impairment, or polyuria. In HHS, there is enough circulating insulin to prevent ketoacidosis, though they have fewer early symptoms that lead to higher glucose levels and more severe neurologic manifestations because of that increased serum osmolality. HHS is a medical emergency with a high mortality rate and a therapy similar to that for DKA. When managing both DKA and HHS, you want to monitor the blood glucose closely, along with monitoring the urine for both output along with the presence of ketones. Also, monitor their IV fluids, insulin therapy, electrolytes, especially potassium, and assess them closely for renal status, cardiopulmonary status, and their level of consciousness. For hypoglycemia, the common manifestations include shakiness, palpitations, nervousness, diaphoresis, anxiety, hunger, and pallor. For the causes of hypoglycemia, again, too much insulin or oral hypoglycemic agents, too little food, delaying time of eating, and too much exercise. It usually occurs at peak time for meds and with disruption in the daily routine. Symptoms can also occur when high glucose levels fall too rapidly. Chronic complications of diabetes. In figure 48-14, we just have a diagram showing the long-term complications of diabetes, which are severe. Everything from stroke, hypertension, cardiovascular system, renal, just to name a few. Angiopathy would refer to the damage to the blood vessels secondary to chronic hyperglycemia. It's the leading cause of diabetes-related death, in two categories, including macrovascular and microvascular complications. The macrovascular complications occur in the large or medium-sized blood vessels, such as cerebrovascular disease, cardiovascular disease, and peripheral vascular disease. It has a greater frequency and earlier onset in patients with diabetes, with women 4 to 6 times the risk for cardiovascular disease, and men 2 to 3 times the risk for cardiovascular disease than non-diabetics. The microvascular disease refers to the smaller blood vessels and involves a thickening of the vessel membranes in the chronic capillaries and arterioles. Areas most affected include the eyes, kidneys, and the nervous system. Nephropathy is another major complication that can occur, involving the damage to the small blood vessels that supply the glomeruli within the kidney. It's a leading cause of end-stage renal disease in the United States, accounting for 20 to 40% of people with diabetes having it. And risk factors include hypertension, genetics, smoking, and chronic hyperglycemia. I spent a few years working in dialysis, and a lot of the patients that are on dialysis for life it is a result of long-term uncontrolled diabetes. The theory is that persistent hyperglycemia causes accumulation of sorbitol and fructose that damage the nerves. These reduce nerve conduction and demyelinization. Ischemic damage to the peripheral nerves also occurs. It may precede, accompany, or follow the diagnosis. Another major issue is going to be sensory neuropathy. And this is paresthesias, tingling, burning, itching, and walking on pillows or numb feet. They've lost the nervous sensation to their feet. And it can be very sensitive. Complete or partial loss of sensitivity to touch or temperature is common. Foot injuries and ulcerations may occur without the patient ever having noticed the pain. Here in figure 48-15, we have a figure of those ulcers that occurred as secondary to neuropathy. In this case, the patient may have just got a small wound that they did not feel, notice, or cared for that developed into a major infection. In the foot and lower extremity complications, microvascular and macrovascular diseases increase the risk for injury and infection. The sensory neuropathy and PAD are also major risk factors. Other factors include clotting abnormalities, impaired immune function, and autonomic neuropathies. Smoking also further increases this risk. Here in figure 48-16, we have the necrotic toe, and there is just a diagram on the left of the before and after amputation. Here in figure 48-17, we also just show further of the skin complications that can occur with diabetes. And finally, infection. That's a defect in the mobilization of inflammatory cells and impaired phagocytosis. Antibiotics should be prompt and vigorous, and include patient teaching to prevent further infections such as hand hygiene and avoiding exposure, along with being vaccinated for flu and pneumonia. But anyway, that's all we got for this chapter. I'll see you in the next slides.